What we've done in Lincolnshire is bring together a linked data set. So we've taken data from hospitals, community, mental health, adult social care, and all of our GP practices in Lincolnshire. We've pseudonymised that, which gives it a level of anonymity, but we pseudonymise it in a similar way across all of the data sets so that we can link them together for unique people without knowing who those individuals are. And what that allows us to do for the first time is understand people's journeys through health and ill health. It allows us to understand what happens for whole cohorts of the population, for people with particular characteristics or particular vulnerabilities. It allows us to understand what works and what doesn't. And it's the first time we've ever had that whole system view, so that we can understand if we do something in one part of the system, what it means for another part of the system. And most importantly, we can understand patient outcomes, because this is what it's all about. So we can understand for the first time how we interact and what our services do to engage people and to support people. We can understand exactly what that does for people themselves. To make sure that our people right across the system can make the best use of the intelligence that we have, we run quite a lot of different work streams. So we have training opportunities for all of the analysts across our system, because we have people from all of our trusts, the county council, from primary care and from the ICB who can all access our intelligence. So the first thing is to really understand what skills they need to get the most out of it and help them to improve those skills, help them to understand how best to use the tools. But one of the biggest things that we've found is that analysts were working quite in isolation. That was very much a demand model for data and intelligence. So what we're trying to change in Lincolnshire is that relationship between decision makers and analysts or intelligence staff. It's wider than just data, to make sure that there's a group of people with different subject matter expertise who jointly own the problem or the question that people are trying to solve, and who jointly solve it. And that includes the subject matter expertise of our trained analysts. And the way that that interaction happens is one of the things we've had to most support, I would say, both from the analyst point of view of being in that environment and taking part in those discussions, but from the decision maker's point of view as well, how they best engage with analysts and how they understand what high quality analytics really looks like. We've definitely seen quite a huge shift in terms of the programmes that have taken part in our population health management programme. Any of those that we support, we take through a particular change cycle and a particular way of understanding the order of events in understanding need, understanding where there's an opportunity to do something different, planning a new opportunity or a different intervention, a change, helping an area put that intervention in place, and then going right through to evaluating it with them. Hugely changed how people work together. We evaluate everything that we do through these processes. So we're starting to get a real understanding of how the way we work has changed the lives of individuals, and that might be the patterns of their service use or the patterns of their outcomes, but it might also actually be case studies on individual patients that have had very life-changing improvements through the way that we work differently to bring services to them. As an analyst and from a background of intelligence, the way that we work, it brings you so much closer to seeing the impact for the population. So previously we would have had analysts that felt very much that they were used in a demand where, we need some data and their job was to provide some data. Now they're in a very different situation. It's their job to be part of the conversation, to own the problem and to help solve it. And when they see the differences that makes to patient outcomes and the differences that makes to very individual patients and the quality of their lives, it really gives them that job satisfaction in addition to any of the analytical satisfaction that they would have had previously. I suppose the big learning point that I would share is that To some extent, a lot of the data things that we do, they're quite tangible. You know, they might be difficult, they might be complicated, but once you understand how you need to bring your data together and you need to put your information governance in place and things like that, they're processes that you can run and run again. The biggest thing that requires the largest amount of effort is cultural change and behaviour change. It takes quite a lot to almost retrain the way an analyst thinks from that demand model to be part of that shared conversation and part of a team that will solve a problem, and to retrain decision makers to make best use of their subject matter experts. And that shared interpretation of the intelligence in the middle is quite a different way to work. So I think the biggest thing that we really probably didn't understand from a data point of view at the beginning was how big that cultural change would need to be. And although it's something that I would say that we're managing quite well at the moment in Lincolnshire, it's still something that we have a long way to go on.